Good evening all, welcome to this new session. We'll try to see some interesting obstetric gynec spotters. So this is the new QR code which I have created for our YouTube channel. So I'll provide this QR code in the comment sections. You can send it and share it to your friends so that they can directly scan the code and subscribe to our channel. So coming to the first case, here you can see this is a female with 5 months of amenorrhea. You can see bilateral echogenic lungs. There is even diaphragmatic flattening and even inversion, and also you can see there is dilated trachea distal to the level of obstruction, and also there is fetal ascites. So this is the video we will play. So this is nothing but a classical case of congenital high airway obstruction syndrome. Next, here also is a other female with 7 months of amenorrhea. You can see there are multiple bilateral enlarged kidneys, echogenic kidneys, and also you can see there are tiny cysts noted scattered throughout the kidneys. So this is whenever you see enlarged kidneys with tiny echogenic cysts scattered throughout the kidneys with mild loss of corticomedullary differentiation, definitely suspect autosomal recessive polycystic kidney disease. If the cysts are larger and kidneys are enlarged, then you can suspect autosomal recessive autosomal dominant polycystic kidney disease. Other differential can be multicystic dysplastic kidney and cystic renal dysplasias. Here this is a 22-year female. Here we will play the video. 22-year female with history of 3 months of amenorrhea, came for NT scan. Here you can see there is a small outpouching noted arising from the defect noted in the occipital bone, and the meninges are seen protruding through the defect. So this is a classical case of occipital meningocele. But here there is other case where you can see there is a complete herniation of the tissues, that is complete herniation of the brain parenchyma through the defect noted in the occipital bone. This is occipital encephalocele, and whenever you see occipital encephalocele and multiple cysts in the kidneys, definitely suspect Meckel-Gruber syndrome. So Meckel-Gruber syndrome is classically characterized by triad of renal cystic dysplasia, that is multiple renal cysts, occipital encephalocele or holoprosencephaly in 70% of cases, postaxial polydactyly or usually hexadactyly, that is in 65% of cases. So remember, occipital encephalocele with polycystic kidney disease or multiple cystic dysplasia, definitely suspect Meckel-Gruber syndrome. Here you can see this is the placenta. There is abnormally thickened placenta with everted margins, and there is a central depression noted in the placenta with even subchorionic collection. And also his cord is not directly inserting into the placenta, it is inserting away from the placenta at the edge of membranes. Here this is that classically placenta, thickened placenta with everted margins with central depression and collection, and this is the fetus. This is the panoramic imaging we have created for better depiction. So this is nothing but circumvallate placenta. This is a placental anomaly in which transition from the membranous to villus chorion occurs away from the placental edge, resulting in central depression surrounded by thickened, raised, plicated gravate matter ring of fetal surface of the placenta. Here the chorionic plate that is smaller than the placental basal plate, which gives this classical circumvallate appearance. So we'll also see this is, you can see this is the circumvallate placenta on the MR images, and also it is typically showing blooming on GRE, and also you can see this is the ring which is typically depicted as a hypointense ring on the MRI, and on these are the gross sections after the surgery. You can see this is the ring which is nothing but gravate matter ring of tissue composed of double fold of chorion and amnion, and with degenerated decidua and fibrin, and this is the typical filamentous insertion of the cord in the membranes away from the chorion. And these are the multiple clots which have been retrieved after exposing the circumvallate placenta. So this is a circumvallate placenta with filamentous cord insertion. So these are the different diagrammatic depictions I have done on my mobile. So this is circumvallate placenta with a filamentous insertion cord. This is circumvallate placenta. This is accenturate lobe. This is filamentous insertion of the cord. This is circummarginate placenta. This is battledore placenta, and this is typical bilobed or biparietate placenta. Here also this other anomaly, you can see the placenta is thickened and there are multiple cystic spaces noted in the placenta, and the fetus is completely seen separate from the placenta. So this is placental mesenchymal dysplasia. So whenever placenta is thickened with multiple cysts, definitely suspect placental mesenchymal dysplasia, and the differentials can be hydropic degeneration of the placenta, complete hydatiform mole with coexisting fetus, chorioangioma, subchorionic hematoma, placental infarcts, and spontaneous abortion. Complications can be intrauterine growth restriction and intrauterine fetal demise. MRI better depiction helps in differentiating between complete hydatiform mole with coexistent fetus and PMD by demonstrating PMD as multicystic lesions within the placenta of fetal sac, whereas that is complete hydatiform mole with coexistent fetus, there will be multiple cystic lesions are located within an extra fetal sac. Next, here also you can see there is a spinal cord. This two spinal cord is divided into two by means of a hypointense fibrous raphe or fibrous septa. So there is two hemichords are seen within the thecal sac. So this is nothing but classical sign is called Mattian sign, because these two chords typically mimics the face of a mask, the Mattian face. So this is face of Mattian or Mattian sign in split cord malformation 2. So this is the QR code which I have generated for our channel. Next, this is also you can see there is a echogenic polypoidal lesion noted in the endometrial cavity, and there are three. This is a classical case of endometrial polyp. There are three signs which you have to remember. Here you can see this is a red arrow which typically depicts the interrupted mucosa sign, because the endometrial polyp focally interrupts the normal mucosal contour of the uterine cavity. This is pink arrows. You can see there are bright edge sign, where you can see there are two linear echogenic echoes, echogenic lines or echoes noted at the borders of the polyps, which are perpendicular to the ultrasound beam. And also on color Doppler you can see a feeding vessel, that is pedicle artery sign or feeding vessel sign, which is classically seen in endometrial polyp and which is seen in 76% sensitivity and 95% specific for endometrial polyps. So the red arrow indicates interrupted mucosa sign. Here the red arrow indicates interrupted mucosa sign, and this is the interrupted mucosa sign. Here this is the two echogenic lines are nothing but the bright edge sign, and this is here also you can see this is the pedicle artery sign seen in endometrial polyps. Here this is a classical case of adenomyosis. Here you can see asymmetrical wall thickening, because the asymmetrical wall thickening is there, and even loss of junctional zone. There are multiple echogenic islands with post-acoustic shadowing. This typically gives the Venetian blind or rain shower appearance. This is the Venetian blind we use in our home. So this is the typical Venetian blind appearance, or rain shower or rain in the forest appearance. And even you can see there are subendometrial nodules. Here you can see these are the subendometrial nodules or buds, and also you can see these are the echogenic islands or subendometrial lines. Here also you can see some Venetian blind appearance, and also you can see there are myometrial cysts. And even there will be negative sliding sign, that is negative sliding sign. The uterus and vagina and cervix will not slide freely over the colon or the rectum, that is negative slide sign, which gives the there will be adhesions which can be seen in adenomyosis and even endometriosis. So this is a classical case of adenomyosis. Here you can see this HHG, where you can see there are multiple endometrial glands, that is the contrast is filling the endometrial cavity, and also it is extending into the endometrial, these ectopic endometrial glands in the myometrium. These are the subendometrial bloods. These are hyperintense endometrial tissue noted in the myometrium with loss of junctional zone, and this is asymmetrical thickening of the placenta, the asymmetrical thickening of the uterus. These are classical adenomyosis. Here this is other case where you can see this is a T-shaped uterus. There is a endometrial cavity is completely narrowed with irregularity, and even it is extending into the tubal surface. So this is T-shaped uterus, classically seen in TB endometritis. And other causes can be diethyl stilbestrol, severe estrogen deficiencies, chronic occipital uses. Next, this is a classical case. You can see I will play the video. This is the typical ovary, where you can see there are multiple echogenic septae, typically mimicking the fishnet appearance. And here you can see there is a cystic lesion with multiple low-level echoes, that is typically mimics sand in bag appearance. And here this is other video. You can see there are multiple low-level echoes which are nearly echogenic or brighter than the endometriotic cyst, and also typically you can see the echogenic lesion with post-acoustic shadowing. So and also you can see hair and dot appearance. So hair and dot appearance with iceberg phenomena. This is nothing but dermoid. So the first case is nothing but this is the hemorrhagic cyst, this is the endometriotic cyst, and this is the dermoid cyst. Thank you all.